Hey, my friends, before we begin, really quickly, 2 weeks ago, we finished up the Awake and Aware 2026 conference, and it exceeded all expectations. It was absolutely amazing. 32 people from disparate backgrounds by the middle of the second day were completely bonded in what I call the bubble, a place where things start to feel a little bit more possible. Change seems a easier proposition than it did before. And we formed a community, and we were learning about finding joy and awareness and meditation, contemplation, communication, and all sorts of amazing things. But beyond those fantastic topics, just the space and time we had created was something that as soon as the conference was over, I wanted to find again. And in service of that, we have already planned the dates for the 2027 conference. Now, the way we do this is in a Kickstarter style. So the Kickstarter is up now. And that means if within 2 weeks we get 18 people to sign up for the conference in Scottsdale, Arizona, February 21st through 24th, 2027, then the conference is a go. And if we don't, then we're not doing it. It's too impossible to set up conferences without knowing we have this foundational base. And to support those people signing up so early, the tickets are at cost. That is the lowest things could go because we're not going to go below cost. So this is the lowest tickets will ever be, is at cost if you sign up now. And once those 18 slots are gone, then the tickets will be significantly more expensive after that. So if this sounds at all intriguing, then just go to awakeawareconference.com. Awakeawareconference.com. All one word, awakeawareconference.com. Now let's get to the show. Hey folks, Scott Weingart here, and this is another episode of the EMCrit One-to-One Resuscitation and Critical Care Nursing podcast. We've been on hiatus for a little while. We're back. We should have regular episodes coming. Though, and I just want to warn you, I don't want this to be a surprise, these episodes will probably be behind a paywall coming up in the near future. You will need to become an EMCrit team member to continue listening to most of these. Some of them will still come out for free, but the time has come to actually have this included in EMCrit membership rather than being foam. And the nursing membership is quite discounted from the doc membership. You get so much else. And that brings us to the next topic of conversation, which is people have been saying, well, some people, I'd say maybe like 20%, they're like, I love one-to-one nursing. I'm a nurse. This is right up my alley, but the level's a little too basic. I want you to delve more deeply into complex topics. And I hear it, but what I have to say to that is you're ready to listen to the EMCrit episodes then. And if there are specific issues that come up as you're listening to the EMCrit and you're like, I don't really understand this from a nursing perspective, or I'd like to hear how this uniquely relates to what I'm going to be doing rather than the doc, then the right move is to then send me questions and I'll hit them up with Candace or other special guests, and we'll actually adapt those within the one-to-one episodes, specifically those questions, rather than redoing an entire complex topic where what you really need to do is listen to the EMCrit episodes. So if you're not listening to the EMCrit episodes, but you're finding one-to-one to be too basic, one-to-one is built to build resus nurses, to take the problem of the brain drain that's happened post-COVID, where all of our experienced resus nurses have become travelers or gone on to other careers. They become CRNAs, et cetera. And we have a whole bunch of nurses who are enthusiastic and smart and ready, but they've not been given the training because there's not time to do extensive training courses like Candace takes her nurses through. That's what this is. So if you're looking for more than the basics, EMCrit is the podcast for you. Just start listening to the EMCrit episodes and then ask questions from there. And then we could just hit those topics rather than doing every single EMCrit episode as a separate one-to-one episode. So hopefully that gives you a state of play. Today we're going to be talking about stroke, ischemic and hemorrhagic, and the particular resus nursing issues that come up with that. And then I think the next episode will be a Q&A episode. So now is the time, as you're listening to this, to get me all of the questions from all of our extent episodes, from any topic that's come up in your mind, anything you want us to hit, all of those things. You've listened to EMCrit episodes now and you have some advanced resus nursing questions. All of that, hit me up soon because the next one we record will be Q&A. All right, let's get in. So Candace, Welcome back to One-to-One Nursing. It's been a couple months. We took a little winter break, but now we're back. How you doing?
I'm great. How are
I am
you?
excellent as well. I figured today we'd do a clinical topic, and the one I want to talk about is stroke, both ischemic and hemorrhagic. How you down with that?
Okay. All right. Yep.
All right.
Sounds good.
So let's start with ischemic stroke. And let's start first with the not severe ones that might actually show up at triage, whether the patient came in on their own or they were brought by ambulance, but they weren't necessarily a stroke notification. Now, triage was a big source of frustration for me in the stroke interactions because basically any vague neurosymptom that might have been there for 3 days in a triage nurse that hasn't quite gotten the full swing of things would send that back to critical care for immediate resuscitation. The patient might have had 2 weeks of left hand numbness. Now, how are you training your triage nurses to arbitrate what strokes are critical resus and which ones could just be in a main department?
I would say that now we definitely do door to CT direct, even from the front door. We gave them some algorithms to follow so that we made the correct decision. I will be 100% honest. I cast a very large net to capture as many patients that could potentially be having an active event as possible. Some of the algorithm will follow the B fast, right? Because that's what's recommended. And we were missing some balance ones, which I'm sure we'll talk about at some point. So that's why we went to the B fast system. But specifically, it stops if the symptoms are greater than 24 hours. So if the symptoms are over 24 hours, we do not do a CT direct. If they are under 24 hours, we will do a CT direct.
And remind me, BFAST is for large vessel prediction or it's for strokes in general?
No, it's for a large vessel and it will help you with like cerebellum stroke. That's what the balance is so important for. I think we've said this before that as a triage nurse, the worst complaint you could get is dizziness
Yep.
because it could be 150 different things, right? And that's where we were really like losing the metric. We were finding after the fact that we could have done something differently with several of our dizziness and balance patients.
That makes complete sense. And we'll talk about these posterior strokes in just a minute. BFAST is going to screen for potential large vessel strokes. What about the patient who does come in with hand numbness? How do you work that when they hit triage?
I think if you are making a decision, is this a disc issue? A person has like chronic neck pain and they now have hand numbness. We still assess speech, ask questions, look at their facial symmetry, do a quick strength test, and then it's all about the time. And unfortunately, people with just hand numbness, our neurology colleagues do want that as an activation for an acute stroke if it's less than 24 hours. But pinning the patient down to when the symptoms started is super important. And you also then need to document that part of the conversation. So, as the triage nurse, if I'm choosing to not activate this as a stroke, then I will indicate that these symptoms started XYZ time, they haven't progressed, they are continuous, or even if they're resolved, right? We don't do active stroke activations for patients that have resolved symptoms, right? We do not do that because what are you looking for? Yes, I think they could be having an active TIA, and that may be a precursor to something large in the future. But if they're not having active symptoms now, we do not send them to the recess space or do a direct to CT.
That's fantastic. That anticipated my next question, which is what you do on TAAs. So that answers that. So why 24 hours? And you might say that's what neuro wants. Large vessel, obviously 24 hours matters. But if they've already screened negative for BFAST and they have like symptoms that could be a stroke, but clearly don't fit into that large vessel category, wouldn't 4.5 hours make more sense for active stroke activation? And again, you might just say that's what neuro wants. So what's the answer, Candace?
Exactly. That's what neuro wants, right? So we do still use the SLAM score as making a decision on whether or not which level of stroke activation we're going to use. So SLAMs is speech, plus the LAM score. And then based on that and the within 24-hour window, so 6 hours to 24 hours, we would make that assessment using the SLAMs. Less than 6 hours, and you feel as if this isn't something that's going to require thrombolytics, we have 2 separate levels of activation. If you're in a small center where you don't have that, then we would do the 0 to 24.
Gotcha. All right. How are you handling triage of possible posterior stroke symptoms? Let's say a patient comes in, I've been dizzy for 4 hours. What do you do with that? Because that could be completely benign, or it could be a sign of a major stroke. So how are you handling that at triage?
Okay. First, we ask them to stand, because if they fail the Romberg or they lean to one particular side, it will cause us to do an activation based on watching them walk and their gait instability and their lean, right? Like I find when we were missing the boat for the patients with these posterior events, they were very clear that they ran into the wall. I'm trying to walk straight, but I keep hitting the wall, right? Like that to me, that needs like a further evaluation, or Meniere's disease or whatever you're thinking it is. But so we do encourage them to just take that extra few seconds to say, what did they look like when they stand up? Are they falling to the side? What did their gait look like when they walked in? Are they in a wheelchair? Can I stand them up and not walk them and see if they could stand just on their own without assistance? I think those extra few seconds help you to really make a concrete decision.
Hey, Future Weingart here. Just to tidy that up a little bit, walking these patients is fantastic. It is a wonderful thing to do at triage. If the patient cannot walk unaided, they are knocking into walls, that would be a cause for a stroke activation. If the patient has an unsteady gait and that's all, that would be consistent with either a posterior stroke or vestibular neuritis, which is a benign condition. So I, in those cases, would think the best thing to do is get a doctor or clinician to do a full posterior neurocheck, a vertigo neurocheck. If you want to find out what that really means, whether you're a nurse, an NP or PA, or a doctor, the best place to go is our spin class, our online dizziness class I did with Peter Johns. And I know this is a plug, but it's an appropriate plug because this will disambiguate all of this stuff. Just go to vertigocourse.com, vertigocourse, one word.com. When at triage are you sending a patient for neurochecks versus doing stroke activations?
We are still sending them for patients that have resolved symptoms because they want an NIH of truly 0 to be documented. And in our facility, the nurse doesn't do that at triage. The nurse will document the SLAMs, and the nurse will document the last known well time in data points in the triage program, but we do not do an NIH. So it's certainly everybody with resolved symptoms and somebody that you are not 100% concrete on. Let's go back to that hand numbness you said, right? And you're like, I don't know, this seems like bizarre. They have this hand numbness. I can't really find anything else. I pretty much think it's just not a stroke and something related maybe to their arm, to their neck, what have you. Those patients, I would say, absolutely could get that.
All right, that all makes sense. Anything else we should mention on triage before we go on?
How about visual changes, right? I think sometimes people forget that a sudden change in vision, you need to think about a stroke as well, right? Those are not ones that you ask that often. Everybody's looking at the face and everybody's listening to the patient's speech, right? But vision, it should play a factor in that as well.
I think that's a fantastic point. All right, let's talk about a stroke that's coming in by pre-hospital stroke notification. And you guys have the Straight to CT program, which is best practice, clearly. And many centers haven't adopted that yet. What have you done to actually make that viable? I was there at the very beginning of that. You might have advanced since then. What are you doing to make this a less tumultuous type experience?
Sure. So we started with just our own emergency medical services that work for Stony Brook Hospital, because we put extra effort into making sure that we could triage out the ones that didn't make any sense. Because we do work in the community doing 911, right? After we figured out what questions do we want to ask and what questions do we want back, which primarily was last known well time, anything that required clarity, right? And then anticoagulant use. We now ask very much about that, and we want to know a blood pressure. I don't really care about the rest of the vital signs unless, the heart rate 0 or significant bradycardia, but the rest of it I could care less about. But I do care about the blood pressure. Then we advanced to just ambulance presentations, right? So anybody that came, so our community services, our professional services, all of them. And we were doing just fine, right? We weren't sending too many. The triage nurse will actually call the stroke activation, and it will go overhead as ED CAT scan. No more of going into the resuscitation bay. We were losing too much time with everybody wanting to do their assessment, and we were wasting time, missing metrics, and we just weren't part of best practice. And then after that became successful, it's the same set of nursing staff members that are working in the back door, as we call it, for our ambulances, or the front door for our walk-in centers. So then we told them, you're doing it back here, you're making good assessments, you can make those assessments on your own at the front door. So the front door now calls direct to CT. They'll make an overhead announcement, stroke activation, direct to CAT scan. And then the physician goes into CAT scan, says, tell me about this patient, and orders the scans right there, and then goes back. But they must get a blood pressure because that's important to know.
How are you getting this blood pressure? Are you putting them on the transport monitor in CT? Are you bringing a transport monitor?
Transport monitor in CAT scan.
Gotcha. All right. And so now the patient's getting their non-con, I think, sometimes even before neurology arrives. And then neurology is going to be doing their exam in the CT scanner,
while the nurse puts in the peripheral IV for the contrast study.
Absolutely. All right. Now, if the CT is negative, are they giving the thrombolytics at that point, or is the patient generally finishing off their scans and then coming back to the room?
I would say we gave thrombolytics and CT scan a very small amount of time, like a handful. For the most part, they come back to the room.
Yeah.
We don't have a Pyxis in our CAT scanner, so you would need to leave the room to go get the meds anyway, and it's a very short walk, maybe 20 steps to get to the medication room. So for the most part, our neurology colleagues very much want an angiogram and a perfusion study before they'll consider thrombolytics globally. There's maybe one neuro stroke attending that's a little bit more okay with just the non-con.
Gotcha. Now, you had mentioned history, and obviously neuro and the ED staff is going to be getting history as the patient's getting their scans. And for a long time, they were using and demanding last seen well versus last known well. And it was a big problem because you'd have a patient who was lucid. They weren't obtunded from their stroke. And they'd say, I was watching this show, and all of a sudden I couldn't move the entire right side of my body. And then neuro would come down and be like, they were last seen well this morning, which was 12 hours ago. And you'd be like, but yeah, the patient is giving a perfect story of their direct onset time. And they're like, that doesn't count. That's last known well, not last seen well. And then there was a big lawsuit in Long Island, not at Stony Brook. And it was on this exact issue. So has neuro changed their stripes finally on this?
Yes. Whatever time the patient gives you, provided they can give you a time, is what we go with.
That's fantastic. All right.
And if the patient can't give you, but maybe a family member can, we go with what they say as well.
Of course. But it just makes sense. Like if the patient is completely making sense to take their... All right. So they're getting the exam. Is neuro doing the full NIHSS in CT, or are they just getting an exam to figure out this patient's clearly a stroke and then finishing that out later?
No, they do it right in CAT scan. They're pretty quick. Pretty quick. And they have those little handheld cards in their pockets. I also hang them and post them on the glove holders. So I put them on a big O-ring, and then I hung them on the glove holder. So it was never that they weren't present and accessible.
Gotcha. All right. So let's say we finish our scans. We're back. The patient's still a candidate for thrombolytics. And I assume you folks have switched to tenecteplase. Is that right?
Yes.
Okay. And so that makes everything much easier. We don't need an infusion. The mixing is not complicated. Now, what is, I imagine, still complicated is getting an actual weight on these patients. which in some AHA publications, they're like, you don't need it. The patient's very clear, I weigh 70 kilos. You could use that as long as you look at them and you're like, yeah, that seems pretty reasonable. Are you guys still adamant about the necessity of weighing the patient?
Yeah, we still leave a stretcher scale outside the CAT scan room. So when that person's direct to CT, that's the stretcher we take inside to move them from the table onto the stretcher.
Oh, wait. So tell me a little bit more about this. So they come in on EMS's stretcher. And
yeah, so they come from EMS's stretcher or in a wheelchair.
And you have a stretcher scale or a weight-giving stretcher outside CT?
A weight-giving stretcher.
Okay, because at some point, remember, we had a stretcher scale that we were using.
We do, but you have to hold that, and people aren't swift at going up and down a ramp.
Yeah.
So no, we bought stretchers with scales, and then every month they're like cycled out for calibration, and every 6 months cycled out for calibration and battery changes and such. And then once a year, I actually lay on them and make sure that the same number comes up on every single one. Because you'd be surprised. You actually have to be in the middle of the bed to get the most accuracy with the brand that we have. I have bought two stretchers that were from a different brand, and they're a different color. They're orange. One, they don't belong anywhere in the hospital but the emergency department. And two, their scale is a little bit better and it has more accuracy. So that if possible, one of those could be left outside or one of the standard ones. And it's tested every morning at 7 a.m. by the incoming clinical assistant staff. And they write a 0 and the date on the sheet so that you know it was tested.
All right. Now, it's pretty clear that unless the patient is on anticoagulants or some other weirdness, you don't have to wait for labs. Though I see in many institutions they are waiting, and that's an enormous amount of time added to the door to thrombolytic time. All right, BP control is an issue. And so we're shooting for the 180 if we're going to give thrombolytics. And this is my space for my nicardipine rant, which is nicardipine is the drug of choice for this, I think, and for all neurocritical care emergencies. But people use it wrong. And if you use it by the manufacturer recommendations, it's going to take you 40 minutes to get the blood pressure down. Increasing every 10 to 15 minutes is not going to work. And even if you started at 5 and increase somewhat rapidly, it could still be 15 or 20 minutes. So in these patients with like sky high blood pressures, what you need to do is go really up to 10, 12.5, 15 an hour very quickly. And then as you start coming near the patient's goal blood pressure of 180, you got to pull back pretty hard. And then the most important thing that gets missed all the time is once you hit your goal blood pressure, you're supposed to drop your drip all the way down to 3 and start slow up titration from that point. Now, this is the part I see missed all the time, Candace. We'll get these patients down to 170. Everyone will be super excited. The nicardipine's at 15. You'll walk out of the room. You'll come back, and they're telling you the patient's blood pressure is a systolic of 50. And you look what happened, and it's because they've stayed on the 15. And this is a failing of the docs and a failing of the nurses because you can't do that with nicardipine. If you've raised it rapidly, that's your bolus. And then you have to pull back to your drip rate. So how are you training the nurses so that they remember this? Because the docs forget, the nurses forget, and then the patient plummets. And this is not the situation you really want low blood pressure. This is not the one where the patients enjoy that as much as they do in other circumstances. So how are you specifically dealing with this issue with nicardipine?
We do start at 5, titrate 2.5 every 3 to 5 minutes, I would say, to get to your goal. And then we typically have you, when you're going to give thrombolytics, you're in the room, right? The nurse is in the room. And at the point where they take the first set of vital signs within the 15-minute mark, that's when they reduce it down to 3.
Okay. That's good.
And then, so they got like that bolus period that kind of went on for about 15 minutes or so. You sustained at 15 minutes, and then you go down to 3 is the goal. That's what we teach them to do. You need to be attentive. So I think a seasoned nurse titrates very differently, right? How I titrate and how other people titrate might be quite differently. I never really followed direction. I made the numbers look the way you wanted them to in the method that I always knew how to do it. Like it's just out of your comfortability with using a pump, your familiar sense with the drugs. And I think that there's guidelines that you should follow, but if you're not paying attention, then you set yourself up for failure. No different if you're using vasoactive drips, right? And it looks great, and you never come back for 20 minutes. It's not going to be great forever, right? You need to be pretty attentive and close to those types of patients. And where you put them in your department, I think in relation to the nursing staff is super important. For us, there's 2 rooms in the corner. I hate those. I hate old people in them, and I hate people on titratable drips in them because nobody goes over there. I'd prefer them to be around the core where everybody is sitting and you can see things flashing and making noise. Just my style. I think that geography is important in how you manage critically ill patients.
Absolutely. All right. Now, a weird issue in the stroke world with thrombolytics is consent, because we are being just hammered to get consent for the dumbest possible things, like consent for a central line on a patient who needs vasoactives and yet we're giving what is, I think, one of the most dangerous drugs we administer. And consent is almost a joke in ischemic stroke. And maybe there's verbal consent with the family. Maybe. I haven't seen written consent in this. It's just implied that everyone will want this medication with a relatively high chance of hemorrhage and worsening. So are you guys still in the same place where consent is?
Yeah, they don't get a written consent. I would say they concretely get a verbal consent because the neurologist will have that conversation. Like, the option is to give thrombolytics or this clot busting drug, whatever terms they're going to use. They're pretty honest about the risk for bleeding, but I think that they don't make that as significant in people with an NIH of 1, right? Like, the NIH is 1, your symptoms are improving, but we're going to give you this medicine anyway. I think that there could be a little bit more of a conversation about risk benefit in that population quite differently than somebody with an NIH of 23.
Absolutely. That's the population I would love. And those are the population you actually have a conversation with the patient about and really talk about it. Yeah, absolutely. But I think it's like this for everywhere. So there's nothing special about it. It's just, for whatever reason, it's just been accepted that this can be done with little consent.
We created a talking point sheet for the neuro residents because we were finding it was taking them a longer time and they were having difficulty talking to the family with good points of information. So we created a talking point sheet, and that's kept right where the timeout is for the tenecteplase. I still have an alteplase timeout because you never know if somebody wants to give that. I don't want the resources to not be there. So I still have it, but it's the alteplase, tenecteplase, and then the talking points in 3 of the cubbies in the core, so that if a physician is struggling or they think they're not going to catch all the points that's there, they could use that as a reference.
Fantastic. If you have a patient who is suspected LVO, obviously it would be confirmed LVO by this point because you'll have the CT angiogram, who's going for intervention, body position is really important. We have a paper showing that if the patients lay flat, they'll actually have a better neuro outcome, and that's just due to increased blood perfusion. Have you guys started adopting that yet?
Yes.
All right. That's great.
We even adopted that in the mobile stroke unit, is making sure that the angle of the stretcher is appropriate for their outcome.
That's great. All right. Anything else on ischemic before we move to hemorrhage?
Do you want to talk about Clevaprax, or you don't want to talk about that?
Yeah, why don't we talk about it briefly? Most of the time I can control patients with nicardipine. What I would reach for is clofidipine if I can't. What is your experience with it, and when are people grabbing it?
I don't like it. And the reason I don't like it is because it's a 90-second titration. And as a nurse who's doing a lot of things, I think it sets me up for an opportunity to have a period of hypotension. So we only use it when you truly fail nicardipine. That's our method. And I have it in the unit. It's refrigerated. I teach people that they have to use low absorbent tubing for that because I don't want anyone bolusing that medication because it does have such a significant change in 90 seconds. So for me, it's not my most favorite drug. I think it could set up the nurse for a bit of a problem, but that's based on the operations of my department, right? Like, you have to make decisions on what works for yours. So we have chosen to primarily use that only when you fail nicardipine. Yeah. But it is present. It is in the order set. It is an option, but I'm still used to something, or I'm still good with what the old drugs were. They work for 99.9% of the people, so I'm good with it.
Yeah, absolutely. All right, let's go to hemorrhage. And I think the issue to speak about first is a patient who's on anticoagulants. Now, Andexxa is gone, thankfully, because that was a huge pain in the butt and it was super expensive and I don't think it worked. So now we're left for most of our Versal with PCC unless the patient's on dabigatran. But I don't remember the last time I've seen a patient on dabigatran. So it's just not really an issue anymore. So how are you folks rapidly finding out if the patient is on anticoagulants, if they're on something like warfarin, or how are you turning around your INRs rapidly? And for patients who are not, how are you empirically reversing quickly? Because it's definitely a point of slowness sometimes in terms of getting the medication, mixing the medication, administering the medication. So how have you made this expedient?
So we keep a dose of PCC in the emergency department refrigerator. It's under lock and key. We do have a full functioning blood bank, right? So our PCC is dispensed from the blood bank. Most organizations, it's dispensed from your pharmacy. It's not for us. And because it has a different mechanism to obtain the product, why it's in the emergency department, right? When you're looking to, and it's signed off on the MAR, it's ordered by the physician like a medication, not like a blood product. And because of that, we were having challenges getting it from the blood bank, right? So we put it in the department, but it is under lock and key, meaning it's in the refrigerator in a lockbox. So you have to go to the Pyxis, type in the key, unlock the box, and take the meds out. It is an empiric dose. Typically is what's available is 2,000 milligrams. So that would be one box of 1,000 units and 2 boxes of 500 units. So you can give 1,500 or you can give 2,000.
What are you guys using primarily?
That's how we stock it.
Are you using the 2,000 as the empiric dose primarily?
For the most part, yeah. But we'd still leave it with the 2 500s just in case there's somebody that they want to give only 1,500 to.
Now, for you and me, it never made much sense why this is so hard to get mixed expediently, but yet it is in many cases. Have you gone to any distance to really get people to be able to mix this quickly?
So I think that now that we're just using tenecteplase, which is the powder to liquid reconstitution, it's improved significantly because it's readily available and it's the same process that you would do to make the tenecteplase. And I find that we've gotten much better. The problem is that there's multiple boxes, right? Yep. So it's not like one box that you're going to do. So you do have multiple boxes, and we do not get a consent for PCC either.
Yep.
So it's in the department. Everybody knows where it is. And I think you asked about INRs, right? Yeah. So we still send our INRs down to the lab. We do have a point of care device that we use on the mobile stroke units. And I do have one in my office that we will use if we need to. But we still send our INRs down. But I'm going to be honest, they don't typically wait for them. They'll just, if there's a bleed and the person's on any kind of anticoag, they just give it.
All right. Anything specific we should mention beyond what we've spoken about for hemorrhagic stroke?
No, I think that's good.
All right. I guess the last question then is, you guys are the primary stroke center, you're the big receiving center, but you have in your emergency medicine portfolio centers that are not, that you actually are managing. How are you folks dealing with rapid transfer, especially for large vessel occlusions where, the intervention is so effective, but if you have to wait 2.5 hours to get there, you have a real chance of losing out on your potential benefit. So how are you managing that?
Yeah, we have other facilities that are quite a distance away, and we have Long Island traffic here, right? In the summertime, it's horrible. So we do station our own hospital-based EMS services there, and they primarily just write out of the CAT scanner. If they believe it to be an LVO, they'll take them from the scanner. Because we have our own drugs inside our hospital-based EMS agencies, so we do it rather quickly that way. Some of the community facilities that are around us, maybe 20, 30 minutes it would take for them to get here, but it's really our sister hospitals that are quite a distance away, and we'll take them right out of the scanner because there's people there.
So the actual thrombolytics will be done in the ambulance by the staff on the stroke units. Yeah, that's great. That's the way to actually cut down that time because it's such a rigmarole to get all the stuff done for thrombolytic administration before the transfer. And we don't even know how beneficial thrombolytics are for LVOs before they get their intervention. That makes a ton of sense. All right, Candace, that was fantastic. Anything else we should have mentioned that we didn't?
I would just say be on top of when you're giving thrombolytics your reassessments. Subtle changes can mean something. And if the person complains of a headache post thrombolytics, take that seriously, right? Because there is a bleed that can happen as part of that. And don't just push it off to be nothing. I think that's important.
How often are you guys doing the neurochecks after thrombolytics?
Every 15 minutes.
All right, so that's Q 15 minutes. And then every hospital that's a stroke center now has to have protocols for reversal of intracranial bleed post-thrombolytics and anaphylaxis. So I assume you guys are just using whatever you have on protocol.
Yeah. And the only anaphylaxis I ever saw with
Hey folks, Scott Weingart here. Just before you go, this episode of One-to-One Nursing is free, so we can get feedback, so people can understand what it's all about. But most of them will not be free. So if you haven't already, now is the time to become a member of EMCrit. And not only do you get all the episodes of the One-to-One Nursing podcast, but you get all the episodes of the EMCrit podcast, which has so much stuff that is directly relevant to your practice in emergency, critical care, and resuscitative nursing. So if you like what you hear, then please join. Just come on over to emcrit.org/join. And I think you'll be really happy to have done so. Bye-bye.
Thrombolytics was when I was with you. That was the only one in all of my years.
Black Cloud, there you go.
Yeah, and it was horrible.
All right, Candace, I can't thank you enough. I'm sure we'll get questions on this, and then we'll answer them in the next show.
Sounds good.
All right, remember what we talked about at the very top of the show? If you're interested in the Awake and Aware Conference, Scottsdale, Arizona, February 2027, then just come to awakeawareconference.com. Check it out. Take a look. awakeawareconference.com. Bye.